case today. And John, we'll let you do introductions.
Okay. Hi, everybody. My name is John. I'm a general internal medicine attending. I'm one of the Clinical Problem Solvers Academy members doing a special session today with our own residents and our morning report here at Huntington Health in the heart of Pasadena. And I'm joined with the esteemed Dr. Jared Fillman, who will be sharing a case with us today. And I see that Seem and Julia are doing our scribing and teaching points, which we really appreciate. Couldn't do it all without you. So I guess you mind unmute and say hi and introduce yourselves too.
Thanks for the beautiful introduction. My name is Julia. I'm a medical graduate from Germany, and I'm very, very excited for the case today.
Hello, everyone. I'm Simi, and I'll be doing scribing today and really excited for the case. Looking forward to it.
Okay. And I think I'll turn the mic over to our guest faculty discussants. And just a little bit about some of the format we'll do is like after each aliquot of information that Jared shares, our guest faculty will share some of their clinical reasoning, and then also kind of open up the court to whatever anyone else wants to add and share any insights of what they're thinking and how they would approach the case. So I'll turn the mic over.
Sounds good. And John, feel free to, it might be hard for us to kind of detect what's going on in the room and how much people are ready, just sort of the timing of when to try to involve folks over there. So please feel free to direct traffic as you see fit if folks want to share thoughts kind of before we do or after or whenever. So we can be as flexible as possible to try to have as many people participate as we can. But excited to hear about y'all's patient, so take it away. And for those who don't know, me and Steph, we're both hospitalists down here in Houston at Baylor, and excited to be part of Wednesday VMR as always.
All right, we'll turn the mic over to Dr. Fellman to share our first aliquot of information about the case. We'll have 6 aliquots in total.
All right, so for our first aliquot, our HPI, we have a 61-year-old gentleman who presented to the ED with abdominal pain and feelings of fever and chills for approximately 1 week. He reports that his pain is epigastric with some radiation towards both flanks. He says that the pain worsens with deep breaths, and he has had some improvement with Tylenol. It is not worsened by eating, but he does have a low appetite since he has developed these symptoms. And he has had a few episodes of non-bloody diarrhea earlier in the week, for which he took Imodium and has since resolved.
Okay, all right, I'll turn the mic over to our discussants to share their thoughts so far.
Great. You want to kick things off?
Sure. So we have a sort of older middle-aged person with fever, some kind of inflammatory process presumed, and localizing to kind of upper abdomen on both sides, maybe the lower thorax, or at least kind of abutting the parts of the body that move when we breathe. And that could include the diaphragms or the upper abdomen. And some clues kind of included already that are helpful when we think about abdominal pain and whether parts of the actual GI tract, kind of the eating apparatus, are involved or not, just because there's a lot of stuff in the abdominal cavity, right? So the fact that the pain doesn't worsen with food is helpful. You would expect processes involving the biliary tree, processes involving the pancreas, or the GI lumen itself to be potentially worsened by the stress test of the GI tract, which is food. So That's somewhat reassuring with respect to involvement of those organs. On the other hand, and by the way, when I say the GI lumen, I mean like the gut along with its sort of vascular supply and stuff too. On the other hand, we have this kind of maybe signal um, of diarrhea, which potentially does kind of invoke involvement of the gut itself. Although it's not a very specific localizer. You can just have a little bit of kind of reactivity where any inflammatory process, systemic stress can cause some loose stools. Now, the fact that it was sort of enough for somebody to take loperamide, and the fact that loperamide can sometimes have a very effective influence on slowing the gut down. We've kind of lost that signal maybe a little bit to see, was there going to be a prominent and persistent kind of diarrheal and potentially GI luminal signal or not. So for now, I guess just to summarize, we have something going on in probably the sort of upper third of the abdomen, maybe on both sides, maybe in the center. We're not necessarily localized to what we think of as the most common sort of cause of abdominal pain with respect to the GI tract and related organs, and it could still be a lower thoracic, upper abdominal non-GI, potentially even retroperitoneal process that we have to keep an open mind to as we look at the background to see what the patient is at risk for, to look for the exam and see where it may localize, and to kind of direct our evaluation subsequently. Any thoughts on that, John, Ruben, et al., or any ideas in the room that we should sort of think of up front as we wait for more information?
Yeah, great discussion, especially about how whether or not it worsens with food is a kind of a big branch point to help you prioritize certain clusters of differential diagnoses. In the clinical problem solvers world, we're all familiar with, like when you're approaching somebody with fever, it's oftentimes a signal of some kind of inflammation. And there's this, well known amongst all of the CP solvers group, the IMAID mnemonic: infection, malignancy, autoimmune, drugs, endocrinopathy. We pair that with localizing symptoms and, thinking about an anatomical approach, and the time course to help us, multiply those factors together to prioritize a differential diagnosis. So we have a kind of acute process that's going on in the, involving the upper abdomen with some signal of inflammation. And when it's a relatively acute time course, you're always kind of prioritizing infection early, especially I think because like an infectious process, if you're trying to treat for something like a malignancy or autoimmune, you're going to make the infection worse. So it's often ruling those things out. So let me ask, does anyone want to teach about, like, if there was any caution you would have with the use of loperamide? Are there any infections where you would have caution with the use of loperamide, and why? Anyone comfortable sharing?
Well, we do. Usually you would want to use it because they get increased toxic production.
It's like increased risk of like toxic megacolon potentially. Good. And with there's one other one that's I think kind of important to remember too. Yeah, like you have these like especially Shiga or Shiga-like toxin producing E. coli. There's a bad complication that you have increased risk of if you have loperamide on board. If anyone know what that is. This risk of like this HUS. So there's some acute infections where you have to be cautious with it. So I think that's kind of like the main things I wanted to highlight here. And I guess Jared, if you're ready, we'll do the next aliquot.
All right. So for our next aliquot of information, we're going to talk about the patient's past medical history, as well as the medications that he's currently taking. So for past medical history, he has a documented history of hypertension. Additionally, he has history of a liver abscess that occurred approximately 10 years ago. Limited data was available on the abscess, just regarding the nature of the abscess itself, but for history from the patient, we know that it was drained and he completed a course of IV antibiotics. And then kind of with regards to his medications, as kind of mentioned, for his fever chills, he was taking 2 Tylenol, 325 milligrams, twice, 2 tablets every 4 hours for pain. And then he was taking the loperamide as needed. We are uncertain on the amount usage, but we do know that it has limited his diarrhea since taking it. And no chronic meds for him, just those kind of 2 medications that he was taking like in the last since symptom onset for him.
We were like, some of the information you probably would have liked, we don't, we didn't have access to, like, what was the microbiological data, some of those, so that, what antibiotics he was prescribed, some of those details were missing when taking care of the patient. But yeah, I'll turn the mic over to our discussants. What do you make of this?
Really helpful. Thanks, Jared. I think both factors in his medical history can help us clue into potential etiologies. When we were first hearing about this guy in his 60s with epigastric pain, my brain was already wondering how many vascular risk factors does he have? Now, this presentation of a week with systemic symptoms, without worsening with food, it didn't fit well the illness script of gut ischemia yet. It didn't sort of fit well with the duration of an aortic syndrome or anything. With an older gentleman, I just will say I was curious up front to know, does this guy have any vascular risk factors that could play into causes of epigastric pain? So he does, right? And so that's enough for us just to kind of put a pin in that. But then, of course, knowing that he's had a liver abscess in the past is really helpful. And I think so true to real life that we know something really important about someone's medical history and don't have all the information. But we need to work with it as we can. So a liver abscess 10 years ago that was drained and treated with antibiotics. I guess stepping back a little bit to talk about how do you even get liver abscesses to begin with? I think most commonly they come from either hematogenous spread, so an organism that you're bacteremic with and that's sort of disseminating throughout the body and sets up shop with the liver. That's most common with bacterial sort of enteric organisms. You can get liver abscesses from contiguous spread from another hepatobiliary type of infection. Those would be the most common ways to get run-of-the-mill, as I said, enteric bacterial organisms, what people would call a pyogenic liver abscess. But you can get liver abscesses from other microbiologic categories, other types of bacteria that aren't traditionally in our enteric gut. So you can get brucellosis, you can get tuberculosis, right? Other sort of inflammatory etiologies from environmental or animal-related exposures. And again, certain ones coming through the GI tract still with foodborne etiology. And then you can get big old things in the liver that aren't quite abscesses, but cause a syndrome of expansion and discomfort in the form of like cystic disease. So depending on where this gentleman came from in the world, whether he's at risk for kind of echinococcal hydatid cyst, but if his story is telling us it was drained and he was given antibiotics, really fits better for a type of microbiological organism. Now, this happened 10 years ago, though. So where I have a little bit of uncertainty is this somehow unresolved from 10 years ago? That seems a little bit hard to believe, although one might wonder if more difficult to eradicate infections are there. Is this completely unrelated to why this guy has epigastric pain and systemic symptoms? That's totally possible. I don't think we can close the door yet on all the other etiologies that the group has come up with. Or is there something in the background for this gentleman in his history that would make him be at risk for having a second pyogenic liver abscess in his life? So those are sort of the possibilities I'm running through my mind. Did this somehow recur? Is it something totally different and we need to be careful not to anchor, or is it a new liver abscess? And again, we'll be getting imaging, we'll be getting exam that'll help us a little bit with that. Anything you want to add to that?
No, that was awesome. I just wondering on like my expiration date of this risk factor.
Oh,
Like I think if the liver abscess was 10 weeks or 10 months ago, even it would be very different than 10 years ago, just in terms of like how likely the current syndrome is to be somehow related to that. But
Yeah, 10 years feels like a long time for it to be the same thing.
Yeah, it's almost like if you had a cancer, right? If it was 10 years ago, now it's more like, even if you have like a new mass now, it's more likely to be a
New
second
cancer.
primary. Whereas if it was more recent, it could be like some kind of recurrence. But
It's a good analogy. What's the group think there?
So anyone have any, thoughts they want to share? And it's okay for camera shy, but I think Himoon and Yaz had a couple of good teaching points in the chat. If you want to just kind of unmute, Himoon had a good point about just kind of a general point about when you're approaching abdominal pain. And Yaz had another good point too, if you're comfortable like unmuting and sharing a little bit.
Yeah, thank you for the opportunity. Yeah, so abdominal pain, if it is like acute, we always think about vascular perforation obstructions. And this patient, I was thinking that using the Tylenol could be acute liver failure with hepatotoxicity, making worse with a liver abscess. And patients maybe a history of hypertension could be like mesenteric ischemia can cause diarrhea. So we can think about that. And also epigastric pain radiating to the right flank could also suggest like biliary colic or cholecystitis or cholelithiasis. So that was my thought.
Good. Yeah, you highlighted the like VIPO mnemonic we sometimes use. So somebody's coming in, abdominal pain and like looking, or especially if they're looking ill, thinking about the life-threatening causes in your first pass, like a vascular cause like mesenteric ischemia, some severe inflammatory process, perforation, or obstruction. So I think ruling out the life-threatening causes first is always important. And yeah, as you mentioned, you had good comments too. Mind kind of sharing a little bit more about your thoughts? Yeah.
Hi everyone. Sorry, can I open my camera right now? But in this case, we have talked about this past medical history of a liver abscess, and as Dr. Steph has mentioned, like we would like to see here, this patient already has chills. I would also look for rigors because literature says that it's a high specificity sign of bacteremia. So I would definitely go back there, evaluate the patient, and see if we should ask for blood cultures. Specifically for the Staph aureus, or maybe a bacteria that can be caused by translocation from the gut. So yeah, those are my thoughts.
Yeah, it's really good. And especially like, the point about differentiating like chills from rigors. Sometimes people just say that they're cold, and that's relatively common. I don't think too much of it. But if somebody has like really like shaking chills, like so that having rigors, you think about it's really something puts a possibility of a bacteremia, especially a gram-negative bacteremia high up in my differential, or possibly a pyelonephritis if you have other clues to think about it that way. Yeah, so yeah, unless anyone else has anything that they want to say, I think we'll turn the mic back over to Jared. Sorry, Jared, I muted you.
No, that's all right.
Sorry, I started over.
All right, so we're going to go through our kind of third aliquot of information here. So we're going to dive into physical exam, as well as some of our first pass labs and vital signs also. So for vital signs, whenever the patient was seen by us in the ED, he had a temperature of 98.4 Fahrenheit or 36.9 Celsius. Heart rate was 83. Blood pressure was 162 over 89. And respiratory rate was 16. Patient saturating 93% on room air. So with regards to physical exam findings, on general exam, he appeared diaphoretic. However, he was alert, cooperative, and didn't appear to be in any acute stress. With regards to his head, normocephalic, no obvious abnormalities, atraumatic. His conjunctiva and corneas were clear. Good EOMs intact, and pupils were equally reactive to light. His lips, mucosa, and tongue were normal. Teeth and gums were normal as well. His neck was symmetrical, trachea midline, no adenopathy, no JVD. With regards to pulmonary auscultation, lungs were clear bilaterally. And for chest wall, no tenderness, no deformity. With regards to the heart exam, no murmurs were heard. The rate was regular and rhythm was regular as well. On abdominal exam, the abdomen was soft, but it was diffusely tender palpation, with more tenderness noted, particularly within the epigastric region. However, there was no rigidity present, there was no guarding, and no rebound noted on abdominal exam. For extremities, they were normal, atraumatic, with no signs of cyanosis or edema. Pulses were 2+ and symmetrical in all extremities. Skin texture, color was normal, no rashes or lesions present. And for neurologic exam, the patient was fully alert and oriented, exhibited normal strength, sensation, and reflexes throughout. And then kind of transitioning from physical exam findings to kind of our first pass labs. So we'll touch a little bit on CBC, CMP, and then the emitting team also, we got a lipase as well, just because of the kind of localized epigastric pain. The gentleman did have a history of alcohol use as well. I believe it was 1 to 2 beers daily. So for kind of pertinent CBC findings on the CBC, he did have elevated white count of 22. And then additionally, he also had a platelet count of 534. Hemoglobin was normal at 15.3. And then for his kind of just some of the information from his CMP that we gathered, sodium was 133. Potassium was 3.2. The chloride was 93. CO2 was 24.1. Renal function was okay with creatinine of 1.14, although, you know, it had been a while since he had followed up. So an exact baseline, we're not entirely sure of kind of where he's at regularly. BUN was 17, glucose was 120. Calcium was 9.3, anion gap was 14. And then with regards to kind of some of his LFTs, his AST was 173, his ALT was 136, and his alkaline phosphatase was 322, with an elevated T-Billy of 3.2. So pause there because I know that's a lot of information.
Yeah, good stopping point. We'll turn over to our discussants.
Thanks, Jared. Yeah, the exam is, I think, most helpful in just showing us the normal vital signs. I think that's really important. The fact that the patient's not having a fever now doesn't, I wouldn't use that as any signal at all. The patient's telling us that they've been having fevers, chills, like I would still think of this as, inflammatory, even if, as a default, even if the white count and the platelets didn't, kind of confirm the same. And then on exam, yeah, just kind of what you'd expect. That, there seems like the center of gravity is kind of in the upper abdomen, but that there's pain throughout, maybe suggesting some kind of generalization or spread of the inflammation, but thankfully without kind of peritoneal signs. So yeah, white count 22, pretty impressive. I always want to see a diff, so I'll ask for that if it's available, please. Just because the different white cells do different things, and which are actually elevated to cause the total elevation is often helpful in knowing kind of the type of inflammation, as well as what organisms to worry most about, as well as what non-infectious processes to worry about, depending on that diff. And then the platelets, are also helpful. Thrombocytosis is a common sign of inflammation, but it tends to happen in cases of sort of more subacute to chronic inflammation. If you think about people that you've all seen with, acute pyelonephritis or acute cholecystitis or, new bacterial pneumonia. Most of those patients don't have thrombocytosis. If anything, thrombocytopenia can be part of like an acute septic process, right? So when I see elevated platelets in a setting of kind of considering an inflammatory disorder, it just tells me either that there's a little bit more chronicity to the process if it's like a pyogenic infection, or it might be a signal for other types of inflammation, autoinflammatory disorders or malignancy that also have more of a subacute or chronic process and can also cause thrombocytosis. So it sort of modifies the flavor of inflammation a little bit. Okay, thank you, Ruben, for clarifying. So it's neutrophilic. That's very helpful. Kind of like fits with stuff we were thinking. But again, right? If it was 50% atypical lymphocytes, or if it was 10 or 20% eosinophils, that would be a very important kind of signal towards some diagnoses. So that's really helpful. Thank you. Okay, and then liver biochemistries. So kind of have a mixed pattern, hepatocellular cholestatic mixed pattern of both elevated ALT, alk-phos, bilirubin. The bilirubin, if you have an indirect versus direct, that is often helpful. So if you have an isolated indirect bilirubinemia, a lot of times that's actually not a liver pathology at all. It might be hemolysis, it might be reabsorbing a hematoma, it might be a touch of Gilbert's. Whereas if you have direct bilirubin elevation, that's much more specific to say, okay, that there's a liver or kind of biliary tract problem here. In this case, because there's ALT elevation, alk-phos elevation, I'm sure part of that total bili is direct. And of course, we just have a lot of things pointing at the liver. Jared, you mentioned a lipase. Did we have the result of that?
So we did. The lipase was 33.
Okay, normal. Okay, good. Yeah, I mean, the pancreas could certainly be in the mix here. And if we had pancreas, sort of signs that the pancreas is involved and the liver is involved, that sort of like localizes right to the ampulla, and you would think a lot about sort of obstruction at that level of whatever etiology. So helpful to know that the lipase is normal, and really we have just a lot of things pointing at the liver at this point, which is really helpful and does change what we would do. So if the LFTs would normal, let me actually just ask the chat / the room, okay? If the LFTs were normal, what would be your imaging of choice? Because this patient needs imaging, right? We need to look inside the body. So if the LFTs were normal, what imaging modality would you use?
Anyone have a preference? Yeah, what you'd order? Yeah, CT, and with any more specificity to it, without, with contrast.
Absolutely, right? So you would want to, a CT abdomen is sort of the default imaging of the abdomen, right? But if you're worried that there's something going on in the liver and biliary tree, it's actually not the best test anymore. An ultrasound is much better, for example, at differentiating liver masses from liver abscesses, because it's better at telling liquid from solid as opposed to just density. And it's just more sensitive for imaging both the biliary tract and the hepatic parenchyma. And if you are ordering a CT to image the liver, you can actually protocol it in a special way, triple phase liver CT that is actually much more sensitive and specific for various hepatic pathologies. Now, it wouldn't be wrong to get both in this case. I think there's sort of enough going on that sort of definitively imaging, cross-sectional imaging for like the perihepatic structures and organs would be pretty high yield too. But I think for somebody with liver pathology, even if we have a CT, I would probably also want an ultrasound.
All right, I think ready to share the next piece then? Or did anyone else have anything else to add before we give the next aliquot? Okay, all right, take it away then.
All right, so for our next aliquot of information, we're going to kind of delve into some of the infectious disease labs. So kind of going right off the bat, a procalcitonin was got, and which was 4.7. Additionally, a hepatitis panel was ordered. Hepatitis panel was negative across the board. And HIV was also gotten, which was negative. And blood cultures were drawn, which I know was kind of mentioned earlier on, just as, something very, it was a lot of people started to pick up on early. And the blood cultures were positive. So they were growing salmonella. So we had growth of salmonella, 2 out of 2 positive blood cultures. So that touches on a little bit of our kind of first ID labs. And then additionally, so we had the source of bacteremia, salmonella bacteremia. Weren't sure exactly where was our source, where was it coming from? I don't know if anyone, if you want to.
Yeah, I guess so the blood cultures grew pretty quickly. I think we could share this, we'll share this bit of information too, but I think the teaching point you're alluding to is whenever you get positive blood cultures, you think of the old, it was the Cotton Eye Joe song, think about where did it come from? Where did it go? Especially if plausible for more sticky bugs. So you have MERS, you have staph bacteremia, you have to think about where it could have seeded. So the blood cultures grew, pretty quickly, and we also, share this bit too with the GI panel grew. The stool studies also grew
Salmonella.
Salmonella.
Yeah. So we actually did a GI panel, which was positive for salmonella PCR, and was followed up with a stool culture, which was also positive for salmonella.
Okay. All right, yes, we'll reserve the imaging for the next aliquot and have this as the break point for discussion now.
Great. Thank you so much. Yeah, really helpful. I guess if I can clarify one thing, Jared, you mentioned you had both PCR and cultures positive from the stool. Was the quick salmonella result in the blood also a PCR-based test, or was it that they saw the organism on gram stain and quickly identified it? I'm just curious from a technology standpoint.
So it was the latter.
That there was blood PCR
yeah.
also. Yeah, great. Just want to briefly just shout out the fact that we have these PCR-based assays that can give us much quicker results now than waiting for cultures. Really just helps immediately, right, on the diagnostic process, figuring out what's going on here. And I think of the data that you gave us, before we knew about the culture positivity, procalcitonin is, tricky to sort of interpret, but when it's kind of close to 5 with this clinical picture, I would say in a way, neutrophilia and bandemia kind of enriches your thought process for bacterial processes. That procalcitonin of 5 just triggered in my mind. Okay, again, we're worried about bacterial infection here. And then I wanted to make a quick comment before chatting about the salmonella about, making sure there wasn't another cause for hepatitis there. And Himun, you just made a great point early on that I want to make sure we emphasize that the amount of Tylenol this person's been taking because they've felt unwell is definitely enough to have contributed it to some drug-related liver injury. So I just thought that was a great point. They're taking 650 milligrams 6 times a day, getting close to 4 grams a day. So is that an element there? We'll see. But back to the salmonella, it's so funny, John. It sounds like both you and I sing the Cotton Eye Joe song on rounds. I think in this case, the question of where did it come from, knowing that there's enteric infection here, sounds like this person got salmonella enteritis from a foodborne source, right? Remember, it takes a very low inoculum to get infected. So that fits the diarrhea and the inflammatory kind of abdominal pain syndrome well. The question of where it went is really important also. Salmonella can, cause pyogenic abscesses in other areas like other bacteria when you have it in your blood. And then it has a predilection too for vascular surfaces. Now, this gentleman hasn't had, as far as we know, vascular procedures, grafts, etc. but this particular organism, important for the group to know when it comes to seeding, has a kind of tropism, so to speak, for vascular surfaces, particularly when there's foreign bodies in there. But could it cause an abscess in the liver? I think so. And so I think, revisiting kind of our desire for imaging in this person, because we know there's salmonella, bacteremia, and enteritis. The question of where it went and whether that explains the mixed liver injury pattern, I think, is going to be important with imaging. Other things we just want to be careful of, revisiting our physical exam for joint issues. I think it'll be an important element. You could get salmonella, arthritis. He doesn't have any prosthetic joints that would put him at higher risk. But when you have a particular organism growing in the bud, thinking about where may this organism actually go and cause problems. And for salmonella, it kind of enrich the usual visceral organs with, as I said, vascular surfaces and arthritis also. Let me stop there and see what else the group wants to add.
Anyone have any thoughts, any questions you would ask, information you want to know, thoughts about where you go next? Yeah.
So I think kind of one question, everyone's wondering, where he got it, exposure history, sick contacts. So I think it's an appropriate time to acknowledge as well that his wife, kind of after, we saw her and talked with her in the hospital, she kind of recalled a little bit of, earlier in the week, I, was actually having similar symptoms where I was having diarrhea and, a little bit of feverish chills, that kind of thing. So, maybe some kind of underlying common exposure there.
I think I would.
Other good points in the chat, like Yaz is wondering about, the immune status of the host. It's kind of thinking along the same lines with the HIV screen. Wondering about these, their signs, Himoon's asking about some signs of like typhoid fever with like rose spots. The patient didn't have any rash, as far as I recall, Jared. Is that right?
Yeah, that's right.
Okay. All right. Yeah.
I was also just wondering if the species is known, whether it is Salmonella typhi versus if it's a non-typhoidal Salmonella species, Typhimurium, paratyphi, whatever. Just because the clinical syndromes are different, and as well as the kind of where the types of exposures. So typhoid fever, Salmonella typhi, is not very common in the U.S. Whereas the others are very common. And just I have a feeling that probably there are liver abscesses again, I would guess. And now it's a very interesting connection to 10 years ago where, typhoid can actually live chronically in your gallbladder. Most of us may have heard of Typhoid Mary, right? This sort of famous person who I think worked in a kitchen and infected like hundreds of people with typhoid just because she was chronically colonized. But from what I remember learning, people who end up with chronic gallbladder colonization of Salmonella typhi don't actually themselves keep getting sick from it. They can infect others, but who knows? Maybe there is sort of a chronic carriage situation and then a systemic reactivation. But that would be very new to me, and I'd have to kind of learn about it from scratch a little bit. I think my best guess is that still this is either just bad luck to have had 2 episodes of what are probably infectious liver abscesses, or maybe, as people are saying, there is some hard to define immunologic predisposition to certain organisms, or maybe something anatomic that maybe predisposes more to sort of portal drainage of enteric infectious organisms into the gut and development of renal abscess or hepatic abscess.
That's it's like it said Salmonella group D, but I don't think, did we have any further specific speciation, at least in our initial labs, we didn't have that. I don't know if with the public health, with follow-up stuff, did we have any additional speciation or?
That I'm not 100% sure of.
So I guess that, at least at this point in the story, we
Yeah.
don't have the specific species. So
It's funny we touched on kind of chronic carriers and typhoid Mary because this patient actually works in like food processing.
Mm.
So they work at a potato chip factory. So it was kind of interesting to note and kind of important for kind of when we touch base on our follow-up to see kind of post-clinical course how that has affected him.
I think we're ready for more.
yeah, take it away, Jared.
All right, so we have now we move on to our imaging. So we have here a CT of the abdomen pelvis with with IV contrast.
Yeah, once if they want to, see if they're able to take a picture. Actually, I don't have it like on our computer where we're broadcasting from. I don't have the picture, but if Seam is able to like share screen with the image before we give the read to the group, that'd be helpful. If not, we'll just do the radiology read.
Yes, I'll share it. Just 1 second.
And we just have a still. We don't have a good movie of it, but figure share a representative image. And like if there's any trouble, don't worry, we'll do the radiology. Probably. Yeah, it's tough just from one image, but anyone in the chat or anyone in the room see anything abnormal that's catching your attention?
I'll just put some thoughts out there. We're seeing just part of the left lobe of the liver, but like right at the top of the screen and the liver under the C, right? There's just kind of seems a little more hypodense compared to the rest of the parenchyma. I think otherwise, we're catching a little bit of the pancreas. That looks okay. There's no stranding. That's right in the middle. And then we're catching a little bit of the, I think, intestinal lumen just to the right of the liver. And the wall maybe is a little bit thickened. It's hard to say just from that. But what I would want to chat with the radiologist about or see if they called in the report is that kind of left lobe, kind of hypodense area.
And it's, I mean, let's look at it too, but does anyone, take a look at the kind of the confluence of the vasculature too. Anyone, if you're kind of focusing there, see anything else that's abnormal? I don't think I would, catch it on my first review.
We're squinting here.
Is that something funny? Anyway.
Not sure.
Yeah. Okay. Well, so let's share the radiology interpretations. We have this, and we also have we got as you requested. We got both the ultrasound and the CT scan for this aliquot. So let's share our radiology interpretation for those.
All right. So for the CT imprint, or sorry, we'll start with the ultrasound impression. It identified, and it kind of hard to tell on the CT just with not having kind of the motion in the multiple images, but ultrasound showed a partial non-occlusive thrombus identified within the main portal vein. It also noted hepatomegaly with a few small round echogenic lesions identified in the left hepatic lobe. Similarly, CT scan impression was age indeterminate bland thrombus of the main portal vein with extension into the both left and right portal vein.
All right. We'll give it back over with that.
So portal vein thrombus with hypodensities in the liver. Yes, couldn't see it well in that. So thank goodness for radiology. I think portal vein thrombus, quickly thinking about why it's there. And I would generally think about hypercoagulable risk, local inflammatory risk next to the actual organs. For example, with pancreatitis, right? You can get portal vein and splenic thromboses. So is there inflammation next to the portal vein? Is there a a hypercoagulable process? And then is just sort of flow and stasis, right? Like that happens with portal hypertension, a factor. In this case, I would say an area of uncertainty for me is whether the systemic inflammation of having Salmonella enteritis itself is enough of a trigger for creating a portal vein thrombosis. I'm just not sure. But back to the question of when you have bacteremia, where do you go looking for it? I would be worried about potential superinfection of that thrombus with the organism that we've had in the blood, and do worry that those hypodensities in the liver are going to be abscesses, and would kind of quickly talk with radiology about the size of them, the number, and whether those are both drainable for diagnostic and therapeutic processes. Because even as we treat the salmonella, whether those abscesses go away without drainage is going to be an important consideration. And then if this is an acute portal vein thrombus, probably appropriate to anticoagulate him as well as part of the therapy to get rid of that, get rid of the nidus again, if possible, superinfection. Do you have thoughts on like whether the Salmonella enteritis itself is enough to explain that being there, or if, we need to go looking for other kind of drivers of that hypercoagulable issue?
No, I don't. I think it's enough, and
Yeah.
I would say it's maybe less the Salmonella enteritis, but rather the actual like hepatic and
Process.
periportal inflammation.
Yeah, makes sense.
And I think but I do want to point out like how different the case is because we have micro from the blood, right? Like this is all Salmonella. It's like the liver, the clot by the draining, in the vein draining the liver, like it all tells a story. I think that it influences management for sure, right? You're gonna treat with antibiotics longer because there's a presumably infected clot there with an organism that can be sticky and cause intravascular infection, right? But diagnostically, like if the blood cultures were negative in this case, we'd kind of be in a bit of a mess, right? Like we'd still be like, is this malignancy or is it infectious? Is it plain vanilla infection that we can potentially treat empirically with, amoxiclav or something? Or or is it an atypical infection with, a mycobacterium or fungus or something else, funky intracellular, zoonotic, etc. We would be much more hard pressed to try to get potentially a tissue diagnosis, which wouldn't be necessarily, I mean, it'd be doable, but not super easy, just because I think that the kind of imaging that both the appearance and the read are almost like sounds like it's more phlegmon than abscess at this stage. And just to kind of define that word, essentially a phlegmon is like an infiltrative infection of a soft tissue that could be muscle, that could be liver, that could be brain, that is maybe in a stage before it has kind of liquefied the tissue and formed an actual abscess around thing with dead organisms and neutrophils surrounded by an inflammatory rind. So that fits with sort of the echogenicity on the ultrasound rather than the hypoechoicness on the ultrasound. It fits with the appearance on the CT that also showed some like contrast enhancement and maybe a little bit of hypodensity, but the shape of it wasn't round, right? It was kind of like just sort of a patchy, almost change in the density of the organ parenchyma. So you could still, it'd almost be like a liver biopsy for micro purposes rather than a therapeutic drainage of an abscess if we needed it, but I don't think we need it because the blood is growing.
Andrew, I just saw your comment. So I guess, yeah, to Zaven's point, thank goodness for the PCRs, because we can say this is Salmonella enteritis that's disseminated to include septic thrombophlebitis of the portal vein with liver infection as well. Andrew just brings up a point, like, is there a chance those hypodensities could be actual infected thromboemboli from the clot itself? I think that's an interesting narrative as opposed to little phlegmon or abscesses. Because the more common scenario where we might see is someone gets an infected IJ clot, and then you scan their lungs, and their lungs have little densities everywhere. I actually wonder if this is sort of a similar pathophysiology. Hard to say, but I think, as we said, the management will be antibiotics, anticoagulation, and then drainage if appropriate. What else you got for us, or Jared, or just the group in general? Would love to hear where your thinking is.
Yeah, anyone share like what you might do to make progress in the next steps, help better understand what's happening? Any other diagnostic tests that could be helpful? In addition, we kind of talked on management a little bit too. Anything else that anyone would do? Any thoughts? We kind of had like, so we had the ultrasound and the CT read, and wasn't there like a bit of a discrepancy between the two, right, Jared?
Yeah, because technically the CT characterized it as like bland thrombus, but are we concerned for like?
Yeah, if I remember, like, did they call like the hypodense lesions? They called on like the ultrasound, but did they call on both the CT and the ultrasound?
So they were called on the ultrasound, but they didn't comment as much on the CT. And then kind of on subsequent imaging, we do have one more kind of modality here. It was kind of less addressed there as well, more addressed on the ultrasound.
Yeah. Okay. Yeah. So we'll share the next. We had these. We were thinking along a lot of the same lines as CEO about whether this is, whether this is like just a regular old bland thrombus, meaning just a standard issue blood clot, or is this infected, or is so we wanted to better understand the space too. So in addition, we did the exact the management that you suggest. The patient was on antibiotics and anticoagulated, and then we ordered a MRI of the liver and to better characterize the liver lesions and the thrombus. I guess you can share that next, Gary.
So on the MRI read, what it showed was kind of redemonstration of portal venous thrombosis extending from the distal most main portal vein into the right and left portal vein. It noted that it is occlusive in the left portal vein and its branches, and there was linear enhancement seen of the thrombus, which could represent septic thrombophlebitis given this clinical scenario. So kind of like, we were talking about before with the CT scan. And then the MRI here also noted no evidence of hepatic abscess. So kind of also addressing that, which we were wondering about as well.
Yeah. And that was kind of surprising, like that we had these like we had this bacteremic patient, and then these like abnormalities on this CT and ultrasound, the MRI, things like. I'm glad to see it. It's like it doesn't have a liver full of abscesses, but we have this clot with these linear enhancements. And we also we talked about this is already the inflammation is kind of creates it's kind of a setup for this too, but we did get some blood work too. We had some basic hypercoagulable basic stuff was sent too. So can share some of that.
Yeah. So for our factor 5, it was negative. The factor 8 activity was over 150. Lupus anticoagulant was negative. For antiphospholipids, beta-2 glycoprotein, IgG, and IgM were both under 10, less than 10 negative. Protein CNS function was also gathered, as well as antithrombin 3 activity and AT3 antigen, all of which were within normal limits. And then a anticardiolipin, IgG, and IgM was also gotten, which was also within normal limits.
And like some of these tests, I think it was like ordered as a panel, but these tests may not be all that useful in the setting in which they were in setting in which we ordered them. Anyone know why? Anything going on that could perhaps muddy your interpretation of these tests? Yeah, Graham, tell me more. Like, how could the clot affect that? Yeah, right on. We also mentioned the patient's anticoagulated, so if the patient's on a heparin drip too, so some of these components of this are going to be uninterpretable. So that's why, like, a lot of times I tend to defer like thrombophilia workup to the outpatient setting after somebody's gotten their treatment for the clot and is able to safely come off of their anticoagulation ideally. But one exception is sometimes is to like look to make sure this if they have any, like say a strong family history, clot in weird places, recurrent strokes, to think about the possibility of like the antiphospholipid syndrome, if you have a clinical syndrome that could be suggestive of it, because those patients are managed differently. You know, they especially the triple positive antibodies, these patients require warfarin therapy. So a lot of the times this other, you find one of the more lightweight thrombophilic conditions, it doesn't even necessarily change your management, at least in-house. You know, you're going to anticoagulate with a DOAC most of the time anyway. So it often doesn't change management. And a lot of the tests are hard to interpret if you've heparinized them or you have an acute clot.
And I think there's also kind of a component of kind of going into our next little bit of information here that kind of, you know, helped prompt the anticoagulation panel and, you know, raise suspicion for, you know, a possible kind of, you know, maybe secondary hypercoagulable state. And this was the fact that during the course of the patient's hospitalization, just as kind of we saw the patient more and as infectious disease and ultimately hematology oncology saw the patient, we did learn a little bit of the kind of prior medical history from his 10-year hospitalization for the liver abscess. And we learned that that course was complicated by thrombophlebitis. And at that time, he was given a 3-month course of Coumadin, but had been off anticoagulation since that time.
Yeah, such is reality. A lot of the times you don't get all of the details up front at the beginning, and you learn more things as you go back to the bedside, as additional people talk, as you talk with family members. So it's a question of like, is this somebody who has recurrent, you know, thromboses, or the other one was also apparently this was happening in the setting of a prior infection. So this is also somebody who's a clot occurring in the setting of an angry infection next door. So you have this pro-inflammatory cytokines, you have some endothelial activation or dysfunction related to it. So it could feasibly be related, you know, just got unlucky and it happened twice that he had clot related to a trigger from an infection. And like the diagnosis, it's not for certain, like we are asking the question, like, is this a bland thrombus or like a septic thrombophlebitis? And I think in the end, we don't really definitively know for sure. Those linear enhancements do raise a suspicion for septic thrombophlebitis. It could have been clot and then it got seeded. You know, Salmonella is a bacteria that is known to stick in endovascular surfaces. It's one of the infections that can cause aortitis, for example. So yeah, that we kind of treated the infection, kind of treat it as if it's a septic thrombophlebitis. You want to kind of share the treatment course and the follow-up?
Yeah, so the patient was initially, whenever he first came into the ED, he was started on Zocin, which was subsequently de-escalated to ceftriaxone. Once we had sensitivities come back, and sensitivity showed sensitive to ceftriaxone, and then the patient was discharged then on Augmentin twice daily for 6 weeks per infectious disease recommendations. Additionally, we talked about the patient was started on anticoagulation in the hospital and then continued on Eliquis. And then we actually saw the patient a couple of times outpatient, kind of in the interim. So the patient actually had, and kind of towards the end of his hospitalization, his clinical status was improving. He was looking quite well. And he ended up having a follow-up abdominal ultrasound 2 months after discharge. And the findings of that, just to kind of touch on those real quick, it showed normal liver echogenicity. It showed that the main portal vein demonstrates patent hepatopedal flow without evidence of any thrombus. So we were able to see some resolution there with this thrombus as well.
Yeah, so good outcome for the patient.
They also did a stool. So they this was recently this month. So he actually had another stool test, which did show kind of trace salmonella still. So he was unable so far to return back to work just because of the nature of his job.
Wow.
Is he putting the chips into bags, or is he just
Can he maybe
like pushing buttons on a machine?
Do some office work for a little while. Poor guy. That's a hard outcome really for a lot of people.
Yeah.
Yeah, it's like it's good in the way that his clot is gone, but it's still like, I guess, important not to forget that this is still something that's having an impact on
Yeah.
his livelihood and his ability
Wow.
to do his usual job.
Wow. Guys, this was an amazing case. My just sort of reflection and parting thought is, just thinking about like the imaging and, Andrew mentioned fake CT liver lesions. But actually, I wonder if it was if in this case the CT and ultrasound were telling you the truth, and it was actually the MRI that was, a false negative. And I try to think of like, for certain questions, certain imaging modalities on average are better than others. But there's a lot of other just sort of other factors, right? Just how the contrast might have been timed, who was interpreting the study that day, where I think that the weight of the evidence, like if on ultrasound and on a CT, like we could see abnormal hepatic parenchymal sort of architecture, and with those LFTs in the clinical context and everything, I actually like my best guess is that probably there was involvement of the liver parenchyma. It didn't evolve into a frank again abscess. We never saw that, but it kind of fits within the story in the labs and some of the imaging findings. And yeah, I think MRIs are sort of like gold standard of the liver, are gold standard for diagnosing hepatocellular carcinoma and differentiating that from hemangiomas or other things, for example. But as far as parenchymal infection or abscesses, it's you kind of have to take multiple imaging modalities as well as the clinical situation together sometimes.
I think, Julia, we can turn it over to you. The only thing I'll say is we are very lucky to be practicing medicine in an age where these PCR-based diagnostics are going to be more and more available. They're very sensitive, very specific. It can help us move along the right diagnostic pathway really much more quickly than waiting for cultures. It's a great case demonstrating that. Julia, take it away with some take-home points.
Actually, so Julia, you're still muted, by the way, but I just wanted to ask John, like, if y'all wanted to actually, it was awesome to see y'all's conference room and everybody there and discussing the case. And but I don't know if y'all wanted to share anything about your program or anything else before we kind of close out with any high take-home points.
Yeah, we spent most of the time on the case, and we'll take a little bit of time, but I'm actually on service too, so I can't I don't have too long to go over. But I'll share, like, I'm kind of the new guy amongst the faculty. I joined the program in the fall here, and they've been very much welcomed and made family at home here. And some information, just besides what you'll see on the website when you read about the program, just a couple things I think that make the Huntington Health family special is like the family dynamic. It's a small program, like there's the eight third-year residents, and just like you work really closely with a lot of the subspecialists. Like the residents all, like, they know the consultants, and they're always just texting, a very close-knit relationship, good collaboration with the specialists, working directly with them. And one of the thing is that it's not something you're going to tell from the website. Is like the ambulatory care center, the clinic. There's something special about the way that they can get the patients in to follow up after their visits. So a lot of times, as in my residency and when I was a hospitalist, we discharged people and we didn't really know what happened to them afterward, unless you deliberately put them on a list and you went back and looked to see what happened to them. And that's really how you learn if you made the right choice, if the treatment that you chose did good for the patient. And they tend, for the like majority, a lot of the patients that the resident will discharge from the wards, they see them back and personally see that same provider back in the clinic. And even for people who may have a different primary care doctor in the community, they often do like one-time like bridge visits where they kind of help to bridge the gap between the hospital and the outpatient world, and see that journey from the hospital to the clinic, and make sure everything's going okay with their prescriptions, with their home health. And seeing and learning from what happens to your patients after you discharge is actually something kind of unique that you'll have that I didn't really see in some of my prior institutions, something special. I also have our associate program director here. You want to like come over and just kind of say kind of few words too. I'll give you my chair.
Hello, everyone, and thank you very much for bringing the problem solvers to Huntington Health. We really appreciate it. And I echo everything Dr. Black says. We're very fortunate to have great faculty. We love Dr. Black. We have other great faculty here. We just really care about our patients, the outpatient setting. And on a different note, you know, just your format, one of my biggest passions is teaching. In fact, I just came back from New York because I work for Kaplan and I teach USMLE Step 1, 2, and 3. And we have lots of foreign medical graduates, and I just have a big passion for them and all their stories. So when I see this format, I just know they would love it so much. I wish that I could just share it. They would love to be here and participate with everyone. So thank you for bringing this here. It's very important. And yeah, thanks again. And if you know anyone who really wants to be part of a great program like Huntington Health, yeah, we're really one big family. Pulmonary, critical care, and sleep. And one of the things I've enjoyed in my career is being here at Huntington. So thanks, everyone. Really appreciate it.
Okay, yeah, I guess like if Julia wants to, you know, if you're ready to do the teaching points, can pass it along, not draw it out too much on our end.
Yeah, thank you so much for bringing this case. I mean, that was a huge journey from like a 61-year-old gentleman that presenting with a very common like initial presentation, just abdominal pain, but our journey first started with like the basic workup we wanted to do in every patient. So think about the localization, the time course, and also the most life-threatening courses we have. So in our case, we try to localize it anatomically with an epigastric region, thinking about the organs that we assume to, or we know that are there, then progressing with the presenting symptom of diarrhea and the food intake that did not worsen any symptoms. So that was just like a very weak localizing symptoms, because the diarrhea was bloody. That was some life-threatening or some severe cause we had in mind. But on the other hand, it could be just due to vascular issues as well. That leads us to our mnemonic. So we think always about vascular infection, perforation, and obstruction issues. And today, Immune also taught us about ectopic pregnancy, something we have to keep in mind, obviously in a female and not a male. One side note we had here was that our patient took loperamide. That is something in combination with toxin producers like E. coli could be a cause of increased Shiga toxin absorption, meaning so an increase in toxicity. That is always something we have to keep in mind to ask the question what medication they took to relieve symptoms. Next, we saw a liver abscess on imaging, and then we were thinking about any causes of liver abscess. So we can divide it in endogenous and exogenous causes. Most likely, it comes from hematogenous spread, but it could also be continuously or pyogenic. In one very important teaching point here was that we should always keep a decline in organ function in mind in the whole picture, so that could lead to like an increased vulnerability for any drug-related issues, injuries in our patient. The other major symptoms our patient presented with was chills. And with chills, we should really differentiate whether it is actually just chills or rigors, because rigors have a high pretest probability for gram-negative bacteremia. So then we should take blood cultures, definitely. The lab reveals thrombocytosis in our patient. And since it was when we think about thrombocytosis, we should divide it in a reactive and clonal. Here we had signs for a reactive process, and that was not completely in line with the acuity of the symptoms. So we were thinking whether there might be a chronicity to the whole process. Next, I love the teaching point you made about the imaging. If we want to visualize liver and biliary tract, the ultrasound is really superior to distinguish masses, so any like solid masses from abscesses. Also, triple phase CT can help us. With our Salmonella PCR being positive, that was a journey from always thinking about when you discover an infection, where's the host, who's the host, where does it come from, the infection, and where does it go? And to kind of put all the symptoms together, we were thinking about the tropism of the Salmonella bug. So it does have a high tropism for vascular, or it can also spread on vascular surfaces, and that was kind of the hint towards like inflammation of the aorta, for example, and also it could still be in mind for a portal vein thrombosis that were discovered later on. Still, if we have a thrombosis of the portal vein, we should think about other causes and keeping the hypercoagulable state in mind, infections, or also malignancy. The last beautiful point I felt Andrew made was that with the portal vein thrombosis and a negative blood culture, we should think about the hepatic lesions not being from septic thrombophlebitis, but maybe just from infarction. So I want to close the session with a great thanks to all of you who were participating really, really nicely in the chat, for everybody being here and learning together. And I feel this program sounds pretty nice, so I encourage everybody to have a look at it and keep coming up to CPS. It's worth it.
Thanks
Thanks,
a lot,
everybody.
Juliana. Thank you, Steph and Zaven, for the great discussion and teaching. We appreciate it.
Tons of fun. Thank you so much, and hope everyone has a great rest of the day. Take care.
Bye.
Okay.